Good afternoon. My name is Russ Derry. I'm the Pediatric Epilepsy Program Coordinator at Mott Children's Hospital, and I'm pleased to welcome you to our very first Epilepsy Expert webinar. And the topic today is surgical treatment options for epilepsy. And we're very pleased to have as our speaker, Dr. Nancy McNamara, who is a pediatric epileptologist at Mott Children's Hospital and the co-director of our Pediatric Epilepsy Surgery Program. Dr. McNamara, you can go ahead and get started.
Hi, everybody. Like Russ said, I'm Nancy McNamara. I'm a pediatric epileptologist here at the University of Michigan. What that means is that I did a child neurology residency and then an additional one-year fellowship, just learning how to take care of pediatric patients with intractable epilepsy and read their brainwaves. The disclosure is I don't have disclosures other than I hate epilepsy and somebody needs to find a cure. Probably most of you on this call agree. So looking forward to that one day when I'm out of a job. So this is a talk I've given for many years now in multiple different permutations for various levels of learners. But I always start off with a pre-lecture quiz. Not that anybody on this call needs to be quizzed, but it's mainly like some key takeaway points, right? And so there's a lot of slides and things, but what are the things that I want you to take away after this talk? And these are not things that are commonly known in the community, even amongst some pediatric neurologists, to be honest. And so out with a little bit of discussion, which we'll talk about, but the first question is, what is the likelihood of seizure freedom from trying a third medication? So probably many of you on this call are here not because your child is seizure free after the first medicine, but you're maybe on seizure medicine number 2 or 3 or 5, 10. And what is the likelihood that they will be seizure free if you just keep trying medicines? So we'll talk about that. What's the average length of time it takes for a patient to get epilepsy surgery? Brain surgery is kind of a big deal. I'm not the surgeon. I'm just the epilepsy doctor who works up somebody for epilepsy surgery. And how long does it take to get this pretty dramatic thing when it's appropriate for a patient? Is it 5 years, 10 years, or 20 years? And does that matter? And why is it important? This is a little bit of just terminology, which may or may not be important to those of you on the call, but how do we as clinicians talk about outcomes? Is Angle Class 1 better than Angle Class 4? The answer is yes, but we'll talk about that. And then what's the seizure-free outcome? Usually talked about 5 years after something kind of standard like a temporal lobectomy. How long, or what's the seizure freedom outcome rate? Because nothing is 100% in medicine. Probably many of you guys are learning that. That nothing in medicine is 100%. Wouldn't it be nice if it was? So just a brief overview of the talk. You can only go through so much in 50 to 60 minutes, but I'll just kind of set the stage with a little bit of background about definition of epilepsy, what's intractable epilepsy, just go into the epilepsy surgery evaluation. There is no way to go into all of this, and it's very individualized, which is the key takeaway. But we'll just kind of talk about some general overviews. Talk a little bit about surgical techniques and mapping that's used right now in 2022. It's come a long way, fortunately. And then we'll talk about outcomes. So background slide. So epilepsy is defined as having greater than 1 unprovoked seizure. There's a couple caveats to that, but these are unprovoked seizures. And probably many of you on this call are very familiar with this. And that intractable epilepsy, which is called by many different names, medically refractory, drug-resistant epilepsy, is when somebody continues to have unprovoked seizures after more than 2 medication failures. That is our timeline in our head when we do try medications, believe it or not, all the time, right? But after we've tried 2 appropriately chosen medications, that's when we start to think about something else, and that's when we deem it as medically intractable epilepsy. It doesn't mean that we're not going to render somebody seizure-free. It's just that's when the scale kind of tips the other way. And then we talk about epilepsy in lots of different terms that you'll hear, but the more commonly used terms that we think about now are the seizures focal, or are they generalized? Are seizures coming from one area, or are they coming from somewhere deep in the brain and hitting everywhere at once? And sort of classically speaking, in order to be a surgical candidate, have to like pause and think about this for a second. In order to be a surgical candidate where you could resect an area of the brain and render somebody seizure free, that's always thought to be that person has to have focal epilepsy, meaning it's coming from one area, preferably a part of the brain that they don't need, where it could be removed safely and not leave them with any deficits. And so that's kind of the classical thinking of epilepsy. And that's honestly like the best case scenario when I meet a patient. That's always what I'm looking for. And for a long time, it was thought that people who had generalized epilepsy weren't surgical candidates. That's not true, but usually that doesn't render them seizure free. So I'll talk about that too. And who should be considered for epilepsy surgery? It's those patients with intractable epilepsy, especially if it's focal, whose seizures cause an adverse impact on their lives. And this is very variable, right? Sometimes it's the longer the seizure, the worse. Sometimes it's the seizures that make you fall or the nocturnal seizures. But I hate seizures, all seizures. And this is just a graph to show you. This is definitely not all inclusive of all the medicines, but this is one of my favorite graphs when I'm thinking about patients and where we've come. We've had medications for a very long time. We have lots of them, like lots and lots of them. So why in the world would we talk about epilepsy surgeries? Because it doesn't always work. It works for a lot of people, but especially some of the older medicines have a lot of side effects and potentials for lots of side effects. So this just shows you the year that medications were introduced and the number of anti-seizure medicines that you have. And this is from like 2010 was this publication. So we have lots more from there, from then. We have other treatments like the ketogenic diet, which is used when people have intractable epilepsy. Some of you might be very familiar with that. So that's a high fat, low carb diet. It's not a natural diet, maybe a little bit more natural for some people than continuing to use medications that can be used to help control seizures. We also have different forms of neurostimulation / neuromodulation that I'll talk about. Those are things that you may have heard about called vagus nerve stimulation, deep brain stimulation. People just used to stimulate anywhere in the brain to see if it helped reduce seizures. So we have some FDA approved things. So VNS is a form of neuromodulation or stimulation that's used in patients with intractable epilepsy. It doesn't make them seizure free, but it was FDA approved in patients greater than 4 years of age that we very commonly use. It is used in addition to medicines. Another form of neurostimulation was FDA approved and is still FDA approved only in adults, called responsive neurostimulation. We use it off-label in pediatrics all the time because we have some patients who are pretty desperate. And then in 2018, deep brain stimulation, a different form of neurostimulation, was added as a potential treatment option. But again, I'm trying to stay on label, but there are some off-label things that we use, RNS and DBS. But this is, why do we do things other than medicine? I just showed you that big long list that's missing a bunch of new medications. It's because most people will become seizure free after the first medicine you try. There's some controversy with these numbers, but this is some good data from 2000 that has been replicated in various forms. But for the most part, how I frame it is, 50% of people will become seizure free with the first medication that you try. Wonderful. I bet you that's not the people on this call. And then you get to the second medicine and you're going to capture a few more. So I use the terms of like 2/3 of people will become seizure free after the second medicine. Fantastic. Great. But then once you get to the third medicine and the fourth medicine, the stats are a little messy here, but what we usually say, it's less than 10% chance that you're going to become seizure free. You still try them, but this is when, in my mind and all of my colleagues' mind as pediatric epileptologists, we say, what else could we be doing differently? Like, let's re-examine things. Where are these seizures coming from? Is there a lesion on the brain MRI that we missed the first time around? So that's when we start to think about other treatment options, very individualized for that patient. So again, most people become seizure free with the first medicine and the second medicine, but when you get to that third and fourth, that's when you're reevaluating things and trying to talk about that patient, that family, all of the things about that patient and what is the right next treatment option. So another way of looking at it, which is the cohort of patients that I primarily take care of, and that we take care of very frequently at University of Michigan, is about 15% of patients with epilepsy continue to have seizures despite good trials of 2 medications. That means not just starting it, that means starting it, up titrating it to sort of optimal or even maximal doses, and then moving on to the next medicine. It really feels like we're playing a game. That's because I don't know if your child's going to need this amount of medicine or this amount of medicine. But once 2 thoughtful choices have been made, it's time to move on. You still try other medications. The goal of epilepsy surgery is not to do surgery, right? It's to render that patient seizure free if you can. But nothing is 100% guarantee. Some patients have different seizure types, right? So sometimes we try to render them seizure free from the really disabling type of seizure. And it's all about the patient and their development. So I want to attack the seizures as early on. If surgery is the right thing, I want to do it sooner, because there's very good evidence to show that they're going to do better long term. They're going to have better cognitive outcomes, behavioral outcomes, better emotional regulation, quality of life, hopefully improve gainful, meaningful employment. Anti-seizure medicines, I keep saying anti-seizure medicines, though sometimes you'll read anti-epilepsy drugs. They're not really anti-epilepsy. They're really just stop the seizures. They just make it harder for your brain to have seizures. They don't really alter somebody's future. This does not mean I'm going to do epilepsy surgery on everyone. I love it when people are seizure free after their first medicine, but I'm talking about the group of patients where they just keep having seizures despite the medications. All anti-seizure medications have side effects, very personalized. We know trends and common side effects from medications. There are some medications that I really don't want my patients to be on long term, just because I know that has a higher likelihood of causing side effects long term than other medications. Phenytoin is a notorious one like that. But other ones, we don't know their long-term side effects, but we worry about it. And we especially worry about it when patients are on 3 medications at a time, 4 medications at a time. So my primary goal is always seizure freedom, but nothing's 100% in medicine, especially in epilepsy surgery. And if we can't render that patient seizure free, I want to decrease seizure burden while improving their quality of life and helping developmental outcomes. And so really the best scenario is when seizures are coming from an area that the patient doesn't need in their brain, which is as important as figuring out where the seizures are coming from. So epilepsy surgery is not an easy evaluation, and it's really variable. Each patient, the kind of seizures they're having, how long they've had epilepsy. Sometimes we're able to do things kind of quickly over the course of weeks, but more frequently it takes months to evaluate a patient for epilepsy surgery. And it's a team approach. It is not just one person saying, oh yeah, your child can have epilepsy surgery, let's go do it. It has to be team-based, and this is the approach across every center in the US. What I always say, and it's probably super frustrating as a parent, is I don't know. I know some basic tests I'm going to do, but then I don't know what test I'm going to do after that until I get the results from the first one. And same thing. Like, I don't want to over test a child, but sometimes I really don't know what test to do next until I get that first one back, if that makes sense. And constantly, I'm trying to not put the child through too much. I'm trying to do least invasive tests before I have to do the more invasive tests. And an important thing worth discussing is why are we trying so hard to stop seizures? We're trying to help the child's development, their long-term outcome. And we know that decreasing seizures does that, but I also, we know that there's an increased risk of harm to patients who continue to have seizures, especially seizures like atonic seizures. And then there's an additional increased risk when children have nocturnal convulsions, especially, and an increased risk of something horrifying to talk about out loud. We refer to it as SUDEP, but it's sudden unexpected death in patients with epilepsy. So if you haven't heard that term, I would just couch it as, this is why I try so hard to get the seizures to go away. This whole big picture of the person. So classic epilepsy candidate is somebody with focal epilepsy, where I'm able to identify where the seizures are coming from. It's something that we use the term non-eloquent cortex, so part of the brain that they don't need. That's complicated in and of itself, but in general, something on their non-dominant side. And then we're able to do a focal resective surgery. We don't do the classic resective surgery in patients who have seizures coming from eloquent cortex. So for example, in most of us, our language comes from somewhere on the left side of our brain. And if seizures are coming from any of those areas where speech is coming from, we don't tend to take that out. We just don't do that here unless we have to, which is very, very, very severe cases where it's threatening the person's life acutely. Same thing with motor cortex. If the child has a fully functioning right arm and leg and seizures are coming from usually the contralateral side of motor or sensory cortex, we try very hard to not take that out because we know that we're going to leave them with a permanent deficit, and we try very hard not to do that except for in extreme cases. So that's sort of the classical thinking. However, there are other techniques that you can use when people have generalized epilepsy or multifocal epilepsy. Like, let's say seizures are coming from a few different parts of their brain. You don't just keep chopping out different parts of their brain. Or if somebody has a generalized epilepsy, meaning everything's getting involved at once, there are palliative options. So palliative means we're not going to cure your epilepsy. You're not going to be seizure-free and off meds. And so those are terms that we'll talk about, like corpus callosotomy, which is you sever the connection between the two sides. And then the neuromodulation that I alluded to in primarily 3 different forms, which is constantly evolving. Something called VNS, which is vagus nerve stimulation, deep brain stimulation, or responsive neurostimulation. And it's so hard, it's like impossible to go through all the risks of epilepsy surgery because it's really dependent on which patient we're talking about and the actual surgery. And so I'll talk to you a little bit about kind of the time frame and how we counsel patients, but what we're always looking for is where are the seizures coming from and how close is that to eloquent cortex. And I thought this was going to be more straightforward when I learned about this in medical school, that, what we're taught, this is the side of the brain we're looking at the left side here, and this is your motor cortex. I thought, it was just kind of simple, like stay away from motor cortex, stay away from sensory cortex, stay away from language. But in reality, everyone's brain is different. And especially if you're a child who's had seizures coming from a malformation in your brain, your brain changes over time and rewires in ways that you can't predict by looking at somebody else's brain. You have to look at that child's brain. So let's talk a little bit about the epilepsy surgery evaluation. So some things that like everyone gets, and then there are some things that are just really dependent on that person, their epilepsy, their tolerance of different procedures. And so everyone gets a very thoughtful epilepsy surgery evaluation. This is not a quick thing. Every single patient needs a detailed history examination. What is that seizure like? What's that first feeling that you get? Because all of that's really important. How have things changed over time? And that's what we all do as pediatric epileptologists. And then the other thing that you can't get away from is you have to have an EEG that captures a seizure. People try to argue this one all the time because I hate seizures. I don't ever want to see my patients having more than they already have. And when I have to bring them into the hospital and watch them have more, why am I doing that? But you have to. You have to see seizures on the EEG because we are just not that smart yet. What if the seizures are coming from the other side of the lesion? That's just malpractice waiting to happen, and you don't want us to do that. So we have to capture seizures on the EEG. And then everyone has a very high quality MRI. You have to do that depending on when the last one was. You might have to do another one. And then there are all these other tests that you can see up here, like functional MRI, PET, SPECT, MAG, which we'll go into a little bit. And really, like, that one's dependent on what the other things have shown. You don't just go and do all of the tests. That's also not right to follow through. Not, a good utilization of healthcare doctors, and, probably extra. And some of these tests are kind of tricky to do. So we just do each one of them thoughtfully. And then regardless of what I think, I have to do a very formal presentation at a conference that has neuropsychologists, surgeons, other epileptologists who are actually, most of them are blinded to the case. And they have to make sure that I'm being thoughtful, that I'm not missing any details, because there's this thing in medicine where you get attached to a patient and you just want to do what's right for them. And you need to make sure that you're not being blinded to them, or just wanting them to have to go through something. So this group it's so important. We meet weekly where we review 2 to 3 cases where we just make sure we're being thoughtful and we're not missing any really important details. And there's neuroradiologists there as well. I forgot to mention that. That's really important. And then depending on what they say, you may go to surgery, you might have to get more testing, or we may say, no, you're not a surgical candidate. There are other tests that you'll read and hear about. A Wada test which is a very specialized test. And then the other thing that everyone has to have is a neuropsycho evaluation with a social work evaluation, speech and language evaluation as well. And this has to do with that whole part of the evaluation of the whole patient, not just their seizures. And I want to make sure that we're not taking out a part of the brain that they need, and that everything is predictive of the best chance of them having surgery with no side effects. So EEG, you have to have some sort of imaging, definitely a brain MRI, detailed examination, and then maybe they'll go to resection. Maybe we'll say we have to capture seizures with electrodes inside the brain. So that's something called phase 2 monitoring, where we say, yep, it looks like we've got a really good hypothesis as to where the seizures are coming from, but we need some more data. So let's do this thing that I'll show you visually, which is where we put electrodes inside the brain and we watch for more seizures. Or no, this patient really isn't a good resective surgical candidate. You haven't really localized the seizures to one area, or it's multifocal or generalized. The answer isn't no, you don't have any options, but then those options become more palliative, or meaning will help the seizures, or we think will help the seizures, but we're not going to render them seizure free. Maybe we can get by with less medication, but you're usually on medication plus having had the procedure. Those are the other necessary things that happen too. So I'm a very visual person. I don't like a lot of words. And so another way of just looking at this is one of my patients who's allowed me to use their brain imaging. And so, I get different pieces of data from every test that we do. So from an EEG, for example, I can see like where the spiking is happening, right? I get like an idea of what we refer to as the irritative zone. So like seizures are coming from somewhere over here, somewhere over here, but that's not like, it's way too big of an area to resect. Those have to trust me on that. That's like huge. But like I can tell from the outside EEG based on they're spiking in between seizures and the actual seizure itself, like it's coming from over here. That's actually a really good theory to have just based on EEG data. But that's not enough to do surgery. So you have to figure out based on the seizure that you capture, where's that seizure onset? Oh, that would be great if I could tell you it came from that red area. But believe it or not, that's still not enough data for the surgeon to go in and resect it, because what'll happen is they will have seizures afterwards, because I just told you there's this big irritative zone or involvement of seizures. Seizures don't actually come from one area, it's a network. So I have to figure out like how much in this network can we take out and make them seizure free, but I don't want to take out the whole thing. Like sometimes we have to do that, but that's pretty rare. So I want to find the least amount to take out. Some tests give me like, oh gosh, don't hit this area here, because if you took that area out, that's the part that they need for the opposite side of their body to move their arm and their leg. That's what we call like the functional zone. So like stay away from that area, right? That's why we didn't take out the big blue area, because we would have given the person a deficit. So I've got to figure out with these other tests, like what has to stay in. Because what I really want to know is what we refer to as the epileptogenic zone. What do we have to take out, not more, not less, to render them seizure free without hurting them? Does that make sense? So that's the goal. So there was one test I could do to do that. That would be amazing. Usually a combination of tests. Another really important concept in my world is brain surgery is like always thought to be a last resort thing, but it's actually not. And there's data that's been around for 15 years now that shows that people who need epilepsy surgery, they don't get it soon enough. And so there's a really scary number. On average, how long does it take to get epilepsy surgery? Hopefully not those patients who are seen here at U of M, but because we're an epilepsy center, right? But a patient in the community who maybe has never been seen by an epileptologist, how long does it take them to get epilepsy surgery? The answer is 20 years. So that's 20 years of seizures, of multiple medications, trying things. I mean, everybody needs epilepsy surgery. It just means that early on, somebody needs to have a thoughtful evaluation by a trained epileptologist, whether it be pediatric or adult, depending on the age of the person, before you just keep trying, other treatments. And so that's a really scary thought. That's a lot of seizures, a lot of development that could have been acted on earlier. 20 years is pretty terrible. And it's because nobody wants their child to have brain surgery. Honestly, I don't want my patients to have brain surgery. But if you know the facts, which is the background I gave you at the beginning, that's why you don't just keep trying medicines, because you just have diminishing returns. And then next thing you know, patients on 6 anti-seizure medicines and they're no better, and you don't know which one to wean, and you're in kind of a bad situation. And so I can see why people get into this, but we have to just face this head on and say, we need to be, evaluating patients earlier on and more thoughtfully than we have in the past. So we have to learn from our mistakes, right? So hopefully we are. Okay, so epilepsy surgery, how do you do it? I don't know, I'm not the surgeon, but I just work the patients up for it. But the best case scenario is when somebody is having seizures from their temporal lobe on their non-dominant side, which for almost everyone is the right temporal lobe, because people who have temporal lobe epilepsy tend to do the best from surgery, and I'll show you that stat at the end. And then when everything's concordant, meaning I've captured their EEG seizure, their seizure on EEG, and their spikes in between those seizures all looks like it's coming from the right temporal lobe, which is right here. We have these very specific patterns that we all have memorized and have evaluated of where in the temporal lobe a seizure is coming from based on what the spiking looks like at the beginning of a seizure. And then there are these other tests that I'll just show you on the next slide that most commonly a PET scan is done, which is a different way of looking at the brain that shows in between seizures that brain is damaged because it's not taking up sugar as well. So in temporal lobe epilepsy, PET scans are awesome, and they can really show you seizure onset and the epileptogenic zone, which is the goal. And then sometimes we also do SPECT scan, which shows increased uptake in the lesion. So let me just show you what those look like, because again, I'm a visual person. So on the left is a PET scan. So this is an example of looking at the brain, like a slice through about here. And I just put up a random patient's PET scan. And so you don't have to like be a radiologist or a neurologist to see that, see how red this is on this side? You see how it's not that red over here? See how it's just not as bright? So, depending on the patient and the situation, this would be quite abnormal to have what we call hypometabolism. This is the left side of the brain, because right and left are switched. And so I wonder, depending on this patient, oh, could seizures be coming from that area? Does that fit with all the other things I know about the patient? Or is this completely like off the wall and different? But like PET scans are very, or can be very, very helpful. And so it really looks, it's just a totally, can you appreciate that this is a very different way of looking at the brain than like an MRI? It's like totally different. So we use this in conjunction. A SPECT scan, which is like my least favorite test to recommend to a patient because of what's involved in it. However, it's like a great test when it all works out right. It's a completely different way of looking at the brain. What happens though for this one, this is an outpatient, PET is outpatient. You just come in and you get hooked up to an EEG for 30 minutes and then you go through a scanner really fast. So like in and out. A SPECT scan, on the other hand, you have to have a seizure while connected to EEG monitoring with an IV in place. Do you see this patient? They have an IV in place. It's a big one, not a little one. And then we have these very highly trained EEG techs watching at the bedside. They already have captured a seizure on EEG. They know what this person's seizures look like. And they watch for the first clinical change. Some people actually have clinical change, but before you can see it on EEG, and then they inject a radio tracer right at the onset of a seizure. So I just told you how much I hate seizures, so we've just induced a seizure, right? We haven't done anything other than like taking away meds or sleep depriving the patient, but like we've made this person have a seizure, which I've never had one, but you don't usually feel that good. And then we inject a radio tracer. Then we have to make sure the patient undergoes anesthesia usually. And then they go down to a specialized scanner. And then they have a SPECT scan. And you actually have to have 2 SPECT scans. You have to have one when you have just had a seizure, and you have to subtract that from not having a seizure. And then it's great when it looks like this, and you see a change in a like a hyperperfusion, a place that tracer went right at the onset of a seizure. So it's a great test, but terrible for a patient. And I hate it every time I have to bring it up. So I always do a PET scan before I do a SPECT scan, right? I don't want to put patients through a prolonged hospitalization and do this, but I also really hate their epilepsy too, right? So sometimes we just make this decision together that we do this. And I forgot to tell you the other really irritating thing is, because there are a whole bunch of people in the hospital and in nuclear medicine and everywhere that have to be here all at the same time, you can't do these overnight. What if you're one of those patients that only has seizures at 2 a.m.? Well, too bad. We have to either switch their sleep cycle or whatever, and we can only do it during daytime hours, which is, it's like that everywhere, just because there's so many people who have to be in the right place at the right time. So as you know, seizures are pretty unpredictable. We can only, do so many things to induce them. We don't give drugs to induce seizures. We only take away drugs or make people sleep deprived to induce them. So it's a big test, but one that we commonly do here, but I try to get away with the other things first. A MEG scan, which is a magnetoencephalography. Maybe some of you, your children have had this, or your grandchildren have had this. This is a very, very expensive specialized test. We actually don't have one here at the University of Michigan yet, just because they're millions and millions of dollars. And it's an outpatient test, which is great. And the child sits in the scanner, and it puts this thing around their head, and it measures the very tiny magnetic current that comes off of every electrical current. And what it does is it just makes it easier for us to kind of pinpoint in the brain where the epilepsy is. Lots of limitations to it, but when it works out well, it can be incredibly helpful. A Wada test is another specialized test, because this all has to do primarily with not hurting somebody. So temporal lobe epilepsy, which is the commonest form of epilepsy, especially in adults, your temporal lobe on your non-dominant side, even if it doesn't have language, it might still have a lot of memory. And if you take it out, you want to make sure that you're not leaving somebody with a memory impairment. And what if your epilepsy is coming from the dominant side, which for most people is the left side, but maybe they've had epilepsy for years and years and years? You want to really counsel them on what kinds of deficits they could have afterwards, or sometimes we just won't do surgery. right? If we're going to take somebody's memory out, we don't do that, right? We try really hard not to harm people. And so it sounds really barbaric, but what we do is we actually have the patient awake. They actually all tolerate it well. It just sounds barbaric. And you actually anesthetize, give medication to put one side of the brain to sleep, and then you test their other side. And then you flip-flop. So we actually do this really commonly. It's actually very, very safe. And it just sounds horrible. But for the patients who have it, they tend to like not really complain about it. The annoying part is that it has to go through your groin, and then you have a room of like 30 people staring at you the whole time. But overall, I think most people would say it wasn't that harmful to go through or that traumatic to go through. It's just a one-day procedure. It actually only takes like an hour or so. But very important. I would want to know what kind of memory deficit I would have after having, if I was going to think about having a surgery like that. And then getting at the whole, remember how I said some people have to have phase 2 monitoring? So some people, like I have an idea of where their epilepsy is coming from. We can use that same case, like their epilepsy is coming from an area, but I really did pinpoint it and to know what kind of surgery they can have. I need to investigate farther, and I need to see seizures when electrodes are implanted. And so for years and years and years, and still done at some centers, but really has fallen out of favor here over the last 10 years, was this picture on the left. So you are actually looking at a brain of a patient who said I could use this. We haven't done a case like this in probably 4 years or so, but this is what was always done in the 80s, 90s, early 2000s, is you have an idea of where seizures were coming from, but then you needed more data, right? Because you needed to see how far away their seizures were from motor cortex or something like that. And so you would put this on top of the brain, and then you'd figure out where the seizures were coming from in comparison to where you couldn't reset. That is a really big procedure, right? So that is taking the skull off the brain, putting this on top. The patients all felt miserable. They all had swelling. They all got fluid collections. There's an increased risk of infection. And depending on which paper you look at, it was like a 10 to 20% chance of you don't tend to die from this, but you would have an infection or some sort of increased risk of infection or something like that, or a subdural, or you just felt junky. Now for the last solid 7 years, because that's when I came on and when we developed our epilepsy surgery program, we predominantly use something that also sounds horrifying, but the patients do much better. It's something called stereo-EEG. So I tried to pick like a similar orientation of a patient. So you have these little teeny tiny, they look big because that's the cap on these little tiny electrodes that are about the same size of the inside of a pen. And they're precisely placed into the brain where seizures are coming from. Again, sounds barbaric, but we spend hours planning this beforehand to make sure we're not hitting a vessel or harming the brain. And then after this gets wrapped up and you don't see it, you monitor seizures just like you would typically in an epilepsy monitoring unit. And then the patient tolerates it much better, with some caveats of like, you have to put it into a muscle right here where they chew. They hate it the whole time. It hurts really bad. You can definitely have headaches. Everybody's pain threshold is different, but especially like in, like, let's say a little toddler, like they're all fine. And it's like nothing happened. And it's much, much, much lower risk of infection, a low risk for a bleed. It's quoted at about 1% per electron. So much lower than the 10 to 20% for what we call a grid. So most places now use these stereo EEG. I presume that most of you here have a patient or a child here at the University of Michigan, and that's what we use here, both on the ped side and the adult side. It's a lot harder on the person reading it, but whatever, like we deal with it. It's much easier on the patient and the outcomes are better than using the old school Subdural. It's hard to see though, isn't it? So surgery, not as simple as it sounds. And I say this because I actually pretty commonly have patients and families who are like, okay, let's do this. Like, let's do that. Like, let's do it this summer. This summer, we don't have anything going on. I'm like, oh gosh, well, we can try. But it takes time. more time if we have it. Sometimes we don't have time and we have to do things really urgently, but you want us to be thoughtful, and we'll tell you when it's ready, if that makes sense. We actually have this very protocolized way here that we like follow, and we make sure patients are hitting the studies that they need and they're not falling through the cracks. And like when we're done, we'll tell you, and you should know everything individualized for your patient, but it's quite involved. And sometimes when we have those stereo-EEG in, because I told you we don't really do the subdural ones anymore unless we had to, but when we have those stereo-EEGs in, we do lots of things when they're in, not just look at the seizures, but we double check and we make sure we'll do mapping of the cortex, and we'll make sure that, you know, we're not in a language center or motor cortex or whatever, and we sort of try to figure out exactly your child's brain. So let's talk a little bit about surgical techniques and mapping. So think about it simply. If there's anything wrong with thinking about things simply, I'm pretty simple-minded. Something that I always want to be able to do safely is a resection. Like seizures are coming from one area that you don't need. The best outcome is from resection. You'll hear about things in the literature like ablation, or when you're researching things. We do that here too. The outcomes just aren't as good depending on the patient and the site. So we'll sort of tell you if that's appropriate, but wouldn't it sound amazing if you didn't have to, you know, commonly for a resection, you typically have to open the skull and go in and dig out a piece. Sometimes we're actually able to do laser ablation, but it has to be kind of a small area. It can't be a large area. And so sorry that my 3-year-old is not being distracted. This is supposed to be, yeah. So that's sort of like the thing that we all want to happen, is for there to be a little area that could come out, but sometimes it's really, really small that we're able to do laser ablation. But that is actually very institution dependent. Sometimes we'll give patients the option of laser ablation, but it is a minimally invasive approach that we sometimes can do. Sounds so dramatic, but sometimes the right answer is actually to do what we call a hemispherectomy, more commonly a hemispherotomy. Like let's say that a child has hemispheric epilepsy, so involving one hemisphere. It's usually their epilepsy is so bad that you're willing to take the risks, or the risks of doing a hemispherectomy were going to happen anyways if the child continues to have such terrible seizures. And so that is done sometimes. Believe it or not, I have some patients who didn't lose anything from their hemispherectomy because they had, for example, a child who had a stroke around the time of birth, had epilepsy coming from an entire hemisphere, so already had damage in that. We did a hemispherectomy and they didn't lose anything. So that can sometimes happen too, but very, very specific, patient cases. And then the palliative techniques, we'll talk about those, just briefly touch on those. But again, those are the things that don't render you seizure free, sometimes involve an implantation, like a vagus nerve stimulation or responsive neurostimulation or deep brain stimulation, or sometimes if you sever the connections between the two sides, which also just sounds horrible, right? But typically when patients need that, believe it or not, they don't lose a whole lot from the disconnection between the two sides. Hopefully they just lose their drop seizures, which is the type of epilepsy that targets. So a standard resection, I think about that as a patient who has seizures coming from the right temporal lobe, typically intractable seizures. And like I have been saying all along, most of us don't use our right temporal lobe all that much. We typically double check and make sure that language isn't over there. They don't have a bunch of memory that they would lose, and the surgeon goes on and resects that. And so it's kind of actually standard. They go up to a certain spot, after which they would hit a vessel that would be really important and increased risk of hemorrhage. And sometimes, depending on which side you're on, you might have to do some language mapping. Hemispherotomy, I at least wanted to show a picture. So this is what I used to think would happen was these are when a patient has hemispheric epilepsy, so coming from an entire hemisphere. What used to happen, and sometimes occasionally happens, is one entire hemisphere would be removed, which sounds just horrifying, right? But what students found a long time ago is that you don't actually have to take the whole thing out, and you actually have less side effects if you just disconnect it. So they'll just leave the hemisphere in. But again, these are for very dramatic cases, like things like the person already had their hemisphere isn't doing anything anyways except for causing seizures. Corpus callosotomy. This is most commonly done for patients with Lennox-Gastaut syndrome who have drop seizures. So it's funny, but like, you know, a drop seizure is just a short seizure. So why is that damaging? It's damaging because on the way down, the child, you know, hits their head on concrete or on the table and causes a skull fracture. And so those can be more debilitating to those patients with that kind of epilepsy, even more than generalized tonic-clonic seizures, for example. And so somebody found out a long time ago that if you sever the corpus callosum in between the two sides, that can really help reduce those really damaging seizures. It can help with other seizures types too, but it's like one of those things that's unpredictable. Who's going to have a lot of their other seizure types help or just their atonic seizures? So we primarily use it for atonic seizures. And then, as I was alluding to earlier, laser ablation can be used in selective cases. It really depends on the patient, where it is, their anatomy. It was actually the thing that got me into epilepsy surgery. Was I was a fellow and had a patient who had epilepsy, was on the other side, on his right mesial temporal lobe, so right here. And he did not, he was clearly, he was on like 4 meds. It was terrible, was seizing multiple times per day. And he did not want to have a craniotomy. He said, no brain surgery, no brain surgery. And so particularly our first case of ablative surgery here on either side, actually, for adults. And they went in and did a laser ablation, and it was 6 years ago, and he's still seizure free. And he was out the next day in the hospital. It was amazing, right? The surgeon actually just went in. It takes many, many hours to make sure everything's lined up. And I make it sound so simple because I'm not the surgeon, but she went in and she did a laser ablation right where his seizures were coming from, and he's seizure free to this day. I check on his chart every so often. It's amazing. So that like kind of got my addiction going to possibly making people's lives a lot better by just a thoughtful evaluation of their epilepsy. Importantly, for the most part, laser ablation doesn't work very well if it's a big area. The outcomes just aren't as good. So if you need a big area taken care of because somebody's epilepsy is from a large area, it's better to actually just go in and resect it. You'll actually do better from an outcome standpoint, tolerating the procedure. Laser ablation is mainly just for a small area. We have had this very specialized robot known as ROSA here. There are a few other robots, but this is the most commonly used robot here, and it's used for stereo-EEG placement. It's used just like this picture that I stole off of online. So the surgeon's doing the surgery, the robot just helps with the math and the lining up of all the different images to make sure things get pinpointed into the right spot. Our first case we actually did, I remember I was there, we only implanted, I think, 4 electrodes on the adult side, and it just took forever to make sure everything was lined up. So somebody very brilliantly came up with this robot that helps things just be completely lined up, and there's no room for, there's always room for human error, but less room for human error, and it just lines up everything precisely. Because when you're talking about putting a little tiny electrode in that can only see so much, it really has to be precise. So just briefly talking about the palliative surgeries, and I'll speed up here so we have a couple minutes for questions. But vagus nerve stimulation is a palliative surgery. It's one of those ones that I always struggled with cognitively. Hey, Ben. So I struggled with cognitively because I didn't really know how it worked. Nobody still really knows how it works, but it does. And we have lots of long-term data to show that it works, but it doesn't make you seizure free. I also sort of struggle with implanting anything into a child. So this is a device that's implanted typically in the left side of your chest. There's a little wire that goes up to the vagus nerve in your neck, and it goes off and on every so often, which then gives feedback to the brain and helps reduce seizures. You do better 5 years out than you do after 3 months, and really minimal side effects. And we can always adjust it so that you have no side effects if you're one of those people who has side effects. Because it's an implanted device, of course, there's risk for infection, but it's really low. And patients tolerate it really well. And there's all kinds of fancy things you can do. If they do have something like sleep apnea, we can make it so that the settings aren't as high when they're lying down and things like that. Responsive neurostimulation, which is only FDA approved in the age of 18 and or older, but as I've already alluded to, we've used it off label. And it's, a big deal to implant something into a child, and especially this actually goes into the skull. So the actual generator itself is placed into the skull, and then you have electrodes placed into where the seizures are coming from. It sounds so clever, right? It then can pick up on the seizure and it zaps a seizure. If you zap a seizure or stimulate a seizure, it actually stops it. And so over time of zapping seizure activity, it really also helps reduce seizures, which is fantastic. And we all love it because we actually, like, I can pull up my patient's data right now if I wanted to, and I can look and see how many seizures he's having, how often he's activating it, what his seizures look like. And most of us in neurology are very data driven, as are many of our patients' parents. And it's really nice to see those seizure numbers come down. But again, it's not first line. I want to do resection in patients, but this is an option if seizures are coming from a part of the brain that you can't remove without leaving a deficit, like language area, motor cortex, things like that. And then deep brain stimulation, also only approved in people who are 18 or older. But as you know, here at U of M, we actually take care of patients until they're 21 in pediatrics. And it's an add-on therapy for people with drug-resistant epilepsy. It's not as clever as RNF because I can't actually see the patient's seizures and things like that. It just goes on and off, typically every 5 minutes. The device is not implanted into the vagus nerve, though. It's actually implanted deep into the brain called the thalamus. And over time, better 5 years than at 1 year, it really, really helps reduce seizure frequency. So I didn't have any good pictures of that one, but that's also a newer thing that we're doing and is very well tolerated. Again, it has to have a battery and a generator, so it lives in your chest. So I just have a couple of outcomes, slides about outcome here. So I'll go through those quickly. So the best long-term efficacy is when somebody has temporal lobectomy. So temporal lobe epilepsy, and then we're able to do temporal lobectomy. Our numbers are not just ours, but universally are in the 70s to 80% seizure-free outcome. So that is not 100%. Nothing is 100%. And if it's anywhere else in the brain, the numbers are not as good. So that is a very important thing to know. So a general rule of thumb is that if seizures are coming from anywhere outside the temporal lobe and the person is like an ideal candidate, the numbers are around 50 to 60% seizure-free outcome. So not in the 80s, not in the 70s, but for some people, this can really be life-changing. And we follow all of our outcomes here, but I think the more important outcomes are when you look at collective outcomes. And so this is actually old. This is from 1998, but still like the largest numbers. So 5-year seizure-free outcomes for temporal lobectomy, like I said, was between 70 to 80%, so 78% here. If it's somewhere outside the temporal lobe, it's around 50 to 60%. If a child has a hemispherectomy, which is not just making them seizure-free, but also potentially giving them more deficits because their epilepsy was catastrophic, outcomes are good, but it's, not even in the 90s, so 70 to 80%. And in general, children do much, much better than adults. Very briefly on post-op med weaning, you don't just like do surgery one day and wean the med the next. It all depends on the patient. But in general, especially like, let's say your child is more typical and is on 4 anti-seizure medicines and has epilepsy surgery, we have to wait about 3 months before we reduce medicines. Not because we don't all want to reduce medicine sooner, but because the healing has to happen, and there's evidence that shows that if you wean too soon, that's the wrong answer. So we just have to wait 3 months because there's all kinds of changes in the brain and the seizure network. But we try to do this hand in hand with the patient and the family of which medicine to wean next. So we'll leave you with that. That's sort of the general overview. You can really only do so much in 50 to 60 minutes. So I'm sorry that I couldn't, talk more, but very importantly, and I only talked about the seizures and maybe a little bit about functional anatomy, but it's all about the patient. It's not even just about their seizures. So this is like a very important thing that we do as an entire group with our social workers, with our neuropsychologists, and with, most importantly, the patient and their families. We work really, really hard to expedite the workup here. We are nowhere close to 20-year wait list. We do things as quickly as possibly, but as thoughtfully as possibly. And we're constantly working on improving our program because we know that no place does this perfectly, but we've come a long way in 6 to 7 years, and we have a lot farther to go. So like technetium 99, I think, is the injection, which actually it's one of those things that is oftentimes not available, or sometimes not available, including this week, unfortunately. It's the trick to injection. You want the injection 30 seconds or sooner in the seizure. We can actually sort of interpret it if it's too soon, believe it or not, but it's just a little bit trickier. And then the time to the scanner is a question we ask all the time. You actually have like a couple of hours, probably have about 3 hours or so. Yeah, so because especially when you're in the hospital, we actually set all patients up for anesthesia if they need it, because a lot of them will need a little bit of anesthesia because they're seizing, or maybe they'll go on and have a cluster of seizures or multiple, and we want the seizures to stop, right? We just needed that one. Also, after seizures, depending on the age of the patient, a lot of people have agitation, somnolence, they can't sit still for the scan, and so we always have to have anesthesia there and present, mainly just in case. They'll just use the minimal amount, though. They're the experts, they're so good at it. And it's really just to keep the patient still for this test that we've just put them through so much to do.
Hey, well, thank you so much, Dr. McNamara, for an excellent presentation